We're coming to the end of our first 2 pilots with wellbeing teams, and this was our aspiration, that we could pay wellbeing workers shifts. Now, lots of home care providers will say that this is what they do, but we were looking at whole 7-hour shifts, because typically shifts would be a breakfast shift, supporting people to get up in the morning and have breakfast, a lunchtime shift, a tea shift, early evening shift, and a shift to support people to go to bed. And usually those shifts would be between 2 and 3 hours long. Therefore, in order to get 7 hours pay, you'd need to do at least 3 of those shifts, which would mean starting at 6:30 in the morning and carrying on till about 7 o'clock, only to get 7 hours in. So we wanted to see if we could think about that differently and pay people for an entire shift. Part of the challenge with home care, carers tell us, is loneliness, and this was brought out in a Guardian article in 2017. So we've been using self-management, we've been using Slack to keep people in contact with each other, and paying for people to be part of a 2-hour meeting every week. And of course, our focus on wellbeing. And in both the pilots, we've been paid by the hour to support people, and this is what we've found. So we found out that it's too financially challenging when you're paid by the hour, however good the rate is. One of the challenges is if you're paying people for shifts, there's a gap when people don't want support. For example, between 11 and 12, everybody should be up out of bed, and it should be before lunchtime. Now, we've explored different ways of filling those gaps with wellbeing visits, but we've not been able to do that with paid work. Obviously, if you're being paid only for the service you deliver, you're not being paid for meetings, and therefore every time the team had a meeting, we were making a loss. And it's also a challenge with cancellations and changes. So local authorities expect us to, if somebody wants to change or cancel their call within 24 hours, that we're able to do that. But because people are working on shift, that then creates another gap in the shift where we're no longer able to pay people because we're committed to paying people on shifts. And also local authorities that maintain 15-minute visits, no provider can make 15-minute visits financially viable. So those are our aspirations, and that's why being paid for the hour can't work for wellbeing teams if we're focusing on people's wellbeing and paying for shifts. So here are some of the solutions that we're now talking to commissioners about. One we'd call Home Care 2.0, where we'd look at a place-based block contract that enables us to pay the entire of people's salaries. That it would be community focused using the ethos of social prescribing, and this is something we've been achieving in our wellbeing teams, where we identify what matters to people and either try and connect them to what's already going on in their community, or if the things that are missing, put them on. And in Wigan we've achieved that through knit and natter groups, from men breakfasts, and through doing work around gardening. And when we have gaps, we can identify people who would most benefit from a wellbeing visit in order to fill those gaps. And of course, by paying shifts, we're also paying people their legal entitlement to a 20-minute paid break. And the current way that home care is provided doesn't take that into account. So Home Care 2.0 is one possibility, and we are having conversations with commissioners in Rochdale. This has also been the basis of the Raglan work in Monmouthshire, and it's also a key element of our next pilot in Thurrock. The next possibility is health and care teams. And again, you'd have place-based block contracts that cover salaries. You'd have a trusted assessor in the team, and all of our teams include trusted assessors, which mean that we can deliver a reablement ethos. We will be able to partner with a discharge team, so be part of supporting people to get out of hospital really, really quickly. We'd use tech-enabled health solutions like wearables and home devices. We would be able to train and support our colleagues in wellbeing teams to undertake basic healthcare tasks and include the social determinants of health via a social prescribing offer focusing on community solutions. And then there's another option, which is whole neighbourhood teams, which is again having place-based block contract that covers salaries, but rather than focusing on older people and people with long-term conditions, this team would be able to support all adults, and this would include young people in transition, people with learning disabilities, as well as older people and people with long-term conditions and people with mental health issues. And of course it would also include the social determinants of health through social prescribing and tech as required. So we're excited about having conversations with various commissioners to explore what we think is the next generation of home care, either home care 2.0, integrated health and care teams, or whole neighbourhood teams. But we also think that the future includes the innovative work of the Equal Care Co-op, so people can choose PA or individual wellbeing workers from a platform, the excellent work of Community Catalyst with micro enterprises, as well as wellbeing teams.